Well, as I've indicated to you, the average chronic pain management program captures that person for 8 hours. They give them a little time, a little break for lunch, just like if they were a regular job. Was that Japanese study done that way? No. You know how many minutes a day? You know, like 8 hours. That's 8 hours times 60. That's what, 480 minutes times, say, a 30 minute lunch break. So what's that? 450 minutes. You know how long the Japanese study was? It was 30 minutes a day, once a week, and it was for the patients that were available or could show up. 30 minutes a week for not a day, not hour a day, 30 minutes. You want to model your interdisciplinary chronic pain management program after the Japanese study because the Japanese study found it was effective? Fine, do that. I probably won't have as much of a problem, especially if you're not billing out $1,000 a day per patient for 8 visits or 10 visits at a time. You know, I mean, my proposal, which is very modest, and like I say, I'm not against chronic pain management. I'm not against use of opiates. I'm against any program which uses patients as revenue generators regardless of outcomes. In other words, if a person is depressed and unable to work and their pain level is an 8 or 9 on a 0 to 10 relative pain scale, and at the end of generating $20,000, $30,000, $40,000 for an interdisciplinary chronic pain management program, they're still at an 8 or 9. They're still having problems with depression. They're still unable to work. Do you think that's an effective program? Do you think that you've shown a good outcomes-based, or as medicine likes to call it, best practices method at that point? I don't think so, and I don't think insurance companies should pay for it. And I don't understand at this point, except for the fact that you have these studies like this PhD who basically, you know, cobbled a bunch of studies regardless of whether they had sham controls, placebo controls, or regardless of it was 30 minutes a day versus 8 hours a day. I mean, if 30 minutes a day is just as good or better than 8 hours a day, why would you keep some poor guy that's hurting all day and charge out $1,000 or $1,600 a day per patient when you could see him 30 minutes like the Japanese were doing once a week and get the same results? Does that make sense to you? That'd be like you taking medication that the Japanese had found you can take one pill once a week for $1, and it did just as good as taking 8 pills a day every day for thousands of dollars. You know, I mean, I might not be the smartest person in the world, but even I can figure out that if you evaluate these programs with an outcomes basis, they might be found wanting, because you have to have some parameters, some guidelines, and to judge whether or not something's effective or not. You know, if you had an infection and you were buying antibiotics that cost you $300 for 10, and you took them for a week and you were no better, and the doctor says, let's do another week and another week and another week, and you weren't getting any better, you'd be upset, wouldn't you? So do you think these guys and gals that are hurting a lot, that are having to drive sometimes long distances to be there at this program at 8 o'clock, be there, exercise, which may turn into rolling on the floor or doing sit-ups for 4 hours? Because honestly, these doctors, these chiropractic doctors that are having to oversee these physical therapy parts of these programs have to be pretty creative. And I feel sorry for them because, you know, once a person has engaged in some stretching exercise and some crunches and some back stretches or whatever, that don't take 4 hours. So what are they doing for 4 hours? And you got to remember, these people are in pain, so they're a little bit irritable. They're often deconditioned, so they tire quicker than someone that's in great condition. So these are appropriate questions, and they should not reflect badly on anyone who has chronic pain or who has to take chronic pain management medication. That's fine. I'm fine with people going to pain management doctors all day, every day if they need to, as long as there's some good outcome, and you know, as long as the doctor can see there's progress being made. But if the only benefit that's achieved from these people being involved in these programs is that the bank account of the whoever, doctor or lawyer or Indian chief, whoever owns multiple clinics, each one pumping out all these thousands of dollars in pain management monies, the only benefit that's really obtained is his bank account's getting bigger, but these poor guys and gals that are hurt and hurting are still hurting, and they're tired and they've lost their gas money driving back and forth there. Then I think that I'm advocating patience when I say they shouldn't be put through that, because I can tell you a lot of people, and these programs to a great degree deal with people injured on the job, workers' compensation cases, that a lot of times they're pretty much told, you go along with this program or you might lose your case. We might abandon you, we might drop you as a patient, and then what are they going to do? So they kind of get into the idea, unless you go along with the program, quite literally, you're not going to have a treating doctor for your workers' comp case, your lawyer might abandon you, and you already can't work, so you won't be getting any money, you're going to be in an awful mess. So there's pressure on these people to go to these programs, and I want that to be clear. And if anybody doesn't believe that, get hurt on the job, get in one of these programs, and see if there isn't a lot of pressure put on you to stay in that program at all costs, whether you feel like you're getting better or not. So, if I upset anybody because they perceived that I was against chronic pain management, or they perceived I was against use of opiates, or I was against pain management doctors, or I was in any way trying to poo-poo the pain that people are having, or make fun of them, I'm sorry, you got a misunderstanding there. If you got the understanding that I was against multidisciplinary or interdisciplinary programs that have as their main goal revenue generation, and really don't give a crap about whether someone gets better or not, but if they kept getting the money rolling in, they would just keep these people coming forever and keep the appropriate reports from the LPC, the appropriate reports from the MD, and the appropriate reports from the DC, that as long as all those reports look good and showed even an inch of progress, that they could keep getting paid, how long do you think these people would be in these programs? I'd say a long time. They might be old and crippled before they got out of the program. So anyway, I'm patient focused. And the last thing I want to say is I really believe that this country is headed for a serious crisis of chronic pain management, of chronic pain, folks in pain who are disabled, who can't get around, and suddenly, because of medical boards, because of law enforcement, find themselves without any hydrocodone, without any OxyContin, without any Narco, without any Lortab, without any of that. There's going to be a real serious problem in the future. And, if you're not hurt now, or you're not hurting now, you might have a dad, a granddad, sister, brother, or, you know what, if you're working, you could be one slip and fall away from being in a program yourself. So my videos are trying to look out for you, not for these fat cats that own maybe 20, 30 chronic pain management programs all across the state, who they just want that money to continue rolling in. If there are such programs out there, I'm against that. If there are programs who put outcomes first, who really care, even if they don't get paid, they're going to treat these folks, more power to you. But I think they need to be looked at by the insurance industry. I think there needs to be sham/placebo controls. There need to be double-blind studies. They need to put people, give them sugar pills, have them go through exercises that are meant not to help you, just to see, are they going to be as good as the folks who are getting the real thing? Honestly, I think that hasn't been done because many people are afraid that the sham group, the placebo group, who are put through what appears to be the program, but not really, appears to be getting the meds, but not really, will be just the same as the folk who are getting the real deal. I mean, it happened with the arthroscopic knee surgery. They found the sham surgery was just as good as the real thing. In fact, a lot of the times when they compare a medical procedure to a sham procedure, the outcomes are equal. So, think about that. If you didn't understand me the first time, I hope I've cleared up any misunderstandings. But remember this, Dr. Baker cares about folks' pain. I've had pain. I know what it's like. It's no fun. It'll mess your life up. It can keep you from working. And I put patients first. And I don't look at them as revenue generators. I look at them as people just like me. Thanks for watching. Bye.